So hi everyone, I hope everyone is well. My name is Dr. Lasker for those that haven't come to any of these talks before, and it does feel like quite a long time we've been doing them. So thank you so much for those that do keep turning up and take part. And yes, very special thank you for donating cases for me to go through today. Hopefully I can do the cases some justice as well. So hopefully everyone can see my screen, and we're going to put the link up very, very soon. So you should be able to access this particular collection. So for those that don't know, this is Collective Minds Radiology, and this is what we're using as the platform to do this teaching. And they're the ones that support this all happening in the first place. And hopefully you'll be able to see, how good of a platform it really is for teaching. And I use it for a lot of my own courses and my own teaching as well. So just if I get a thumbs up that you can hopefully see the case that I'm opening up. So this is case number one. And this will, once it loads up, you should be able to see a chest x-ray. Can I just get a confirmation that I've definitely shown the right tab? Because sometimes that happens where someone has raised a hand. Okay, good. No, that's perfect. Excellent. So what we're looking at here is a chest x-ray, right? And first off, what I always do when I'm having a look at this chest x-ray is have a quick look, see if there's anything obvious. If there's nothing obvious, then we've got to start looking at, let's have a look at the orientation of this x-ray and see what it looks like. So when you come to this kind of orientation, as in how is the patient actually facing the plain film, you can see that sort of medial edge of the clavicle is over here, and that other edge of the clavicle is over here. But when you look at the spinous process, that's all the way over here. So they're slightly rotated, aren't they? They're kind of rotated maybe this way. This is not quite an en face image, right? And so this is, so we have to take that into consideration. That if we see any sort of, sometimes people say, look, that hilar looks really, really big. But then actually you have to take into consideration the rotation of the patient. And if you've got sort of a V-like structure, and then you kind of turning, will start to look more tubular and more round, and then you start to say that there's something abnormal. And if you do think there's something abnormal in that area and the patient's very, very rotated, you may need to send them back for another X-ray to make sure that there is no actual abnormalities and not actually secondary to the rotation. So a few people have given the answer. That's brilliant. Someone has written something else. Yeah, that's a good shout as well. So we're going to have a go. We have to go through this in a systematic manner, right? So I usually have a look at the lung apices and make sure that they look okay. And if we look at this one and zoom in, so we've got the zoom function here, and we sort of pan across like this, we can see that actually these lung apices don't look quite the same as one another. And for those that can't see it, if you look at that left lung apex, you see these linear kind of lines going all the way up like so, all the way up like so, all the way up like so. But if you look at this side, the linear lines go all the way up to here, all the way up to here, and all the way up to here, and then they just completely stop. And actually all this looks very, very clear. And that can be a little bit difficult sometimes if you're not entirely sure. What you can do is draw a little square like this and draw a little square like this. And one of my consultants used to actually do a little kind of square like this, do a square there, do a square there, and really compare between the two. And once you do that, you can say, yep, you know what? There's definitely a difference in the sort of texture of the lungs there, i.e. there's no lung there at all located within that right apical region. So we could all stop there and say, yeah, you know what, we're sorted, it's done now. But actually we do have to think about like, what else could be happening here? And someone actually touched upon the possibility that there is some blunting of that right crostophrenic angle. So if we look at that right crostophrenic angle, we can actually see, yeah, you know what, there is something going on here that looks like a straight line. And you should never really have any straight lines in the human body, really. Most things are kind of curved or kind of wriggly and stuff like that. You shouldn't have straight lines. And when you've got straight lines, either someone has put something in there, or it's like a fluid level or some sort of difference because of gravity. And you can see, yeah, there is probably some sort of blunting of the crostophrenic angle. And these are the times when you've got to be worried that, you know what, there's some fluid there, and you've also got a pneumothorax. So what could that mean? It could mean that they've had a bit of a traumatic injury. That could mean that they had a rib fracture of some sort, which can puncture the lung, and they could have bled and all that kind of thing. And that's when you really got to do the hard graft and start looking at the ribs. I'm going to do the ribs just so that we can, you're going to get hemorrhages as well. So you can have like nodules, like a lung malignancy, I suppose, that can bleed. And yes, I guess in theory, there could also be weak points where you could have a pneumothorax. Not very usual, but it could happen. Sometimes patients have had, this can be iatrogenic. So they've got a lung nodule or a lung lesion, and they've gone through with a biopsy needle and they punctured the lung, essentially, and then you end up having a pneumothorax. Sometimes central lines can do it. There's all sorts of reasons that you can have punctured lungs, right? And sometimes they're just spontaneous. We don't exactly know why it happened or what happened, but we can just have a look like this and just have a good look around the ribs. And the way to do it is to really follow the ribs right from the back all the way around the side. And this is where it gets a little bit confusing. But if you really do follow, you can see all the way to this edge. And then you've got the anterior edge of the ribs. And just do that for every single rib, right? So let's have a look. and just make sure there's no obvious fractures anywhere. And actually, on this particular X-ray, I can't say that we've seen any fracture, but there is definitely a fluid lesion, a fluid level there. So we do have to sort of highlight that. So if I was reporting, I'd say that there is a right-sided pneumothorax. I'd measure the distance that the pneumothorax depth would be, and I'd also say that there's some fluid located within the right hemithorax. And then in the context of trauma, this could be hemothorax. In the context, in it could be anything really, until someone tries to put a tap in and with a bit more clinical information. But the main things you can really say is, yeah, 100%, there's a pleural effusion, and there is definitely a right-sided pneumothorax. And they're quite a young patient as well. So it'd be a bit surprising if there's going to be something sinister like a malignancy and that kind of thing. Because when you actually look at the bones and the edges of the bones, they look very, very flat, very kind of pristine. They don't look like an old person. And then also when you get older, you can actually get calcifications of that sort of the more chondral areas of the rib cage, and that doesn't look like that's happened here either. So this must be a youngish person who's ended up with this kind of particular issue. So anyway, yeah, a few people have got that. It's very well done. Fine, let's go to case number 2.